Welcome to my system of learning and teaching that is fun, learn and earn. I am Dr. R.K. Dua, I am a surgeon. So today's topic is again shock. So in hypovolemic shock you must have observed what exactly is the shock. So by the name of shock, if somebody says that that patient is going into shock, that can cause so much reaction in the body, in the mind of the attendants, that cause something like a terrible thing is going to happen. So we have already discussed what are the various types of the shock. We have discussed the hypovolemic shock, its causes and pathophysiology and its treatment. So the next shock is your septic shock. So what exactly is the septic shock? As in case of hypovolemic shock, there was a loss of fluid from the body. That was in the form of blood, in the form of fluid, sweating, loose motion and vomiting. But in case of septic shock, there is exactly no loss of the fluid from the body. So where does then the fluid is going? Fluid is going into the third space. That means it is moving out of the vascular system and going into the interstitial spaces, third space. So when it moves out of the circulation, it will cause the decrease in the blood pressure, decreased tissue perfusion and altered cellular metabolism. So ultimately in any kind of shock, the main result is altered tissue and cellular metabolism because of hypoxemia, low oxygen concentration. Similarly, in case of septic shock also this occurs, and this septic shock occurs mainly in the presence of gram-negative bacteria. The cellular structure of the gram-negative bacteria that cause the endotoxemia and lead on to all the features of shock. So those features of shock, mainly loss of fluid, hypovolemia, hypoperfusion and hypoxemia, altered tissue metabolism. So we must have, in case of endotoxic shock or septic shock, the clear-cut source of infection. So most common source of infection is your urinary tract infection, where the infection is most of the time is caused by your gram-negative bacteria. So all these things ultimately lead on to the hypoperfusion. Let's dive into your mind map. So you can see here what are the various causes of septic shock. So these are the gram-negative organisms which are present in the septic shock. E. coli, Klebsiella, Pseudomonas and the sometimes gram-positive can also cause septic shock, mainly when polypeptide glycans and teichoic acids present in the cellular wall of the gram-positive bacteria. When these bacteria enter in large quantities, and these can also cause septic shock. So urinary tract is the main tract of the body that is mainly infested or infected with gram-negative bacteria. That may be E. coli, Klebsiella, Pseudomonas or any other gram-negative bacteria. So this septic shock is actually a part of systemic inflammatory response syndrome. That's why whole of the body is affected by your endotoxemia. So when our inflammatory response takes place at a local site of the invasion by the bacteria, but when that bacteria is not contained, ultimately that spread onto whole of the body. So that lead down to systemic inflammatory response syndrome. That means inflammatory response that remains controlled to cause the healing of the body. Now that same inflammatory process is acting against the body. So what, and this septic shock is not common in case of trauma, except when the trauma is old and there is infection in the road traffic wound from the dirt outside the body. So that can cause septic or your endotoxic shock. So hypoperfusion despite adequate fluid resuscitation. So that means fluid, whatever the fluid we are giving, still the patient is not responding because the endotoxemia has taken over the control from the immune system. Now they have taken the control. So that's why whatever the fluid which we are giving, that is extravasating from the vascular system into the extravascular space. So ultimately what will happen? Hypertension, hyperperfusion, then oliguria and anuria. Though it is a part of systemic inflammatory response syndrome, when kidneys goes into failure, ultimately other organs will also start into failure state, and ultimately patient may go into multiple organ dysfunction syndrome, and ultimately death of the patient can occur if that is not controlled in a time. So ultimately, as we can see, the pathophysiology of the septic shock, same we have discussed. There is peripheral vasodilatation along with extravasation of the fluid. So both things, vasoconstriction maintain the blood pressure, but vasodilatation increase the capacity of the vascular system but decrease the volume. So blood pressure suddenly falls down. Renal perfusion goes down. So increased peripheral vascular permeability, that means fluid is going into the third space. Myocardial depression also occur because of endotoxins. That means already there is decrease in the vascular volume, there is increased peripheral vascular permeability. Over that, pumping station is also not pumping properly. So peripheral arteriovenous shunting will also takes place because capillaries goes into constriction and the blood directly goes from arterioles to venules. So that means peripheral perfusion will also be affected. So uncoupling of oxidative phosphorylation, that means less amount of energy will be produced from the metabolism of the food. And as it is a part of systemic inflammatory syndrome, so there is always a confirmed source of infection. So whenever we are suspecting that patient is suffering from septic shock, we must always look for urinary tract infection. If the patient history is not suggesting, still we have to do the urinary examination routine as well as culture. Along with that, we also have to do the blood culture also. So hypotension, hypoperfusion despite adequate fluid resuscitation, and this is uncommon in trauma unless the delayed presentation, because by the delayed presentation means infection which has gone into the open wounds has caused the endotoxemia and patient may go into septic shock. So in septic shock, various kinds of pro-inflammatory things are produced by the monocytes, neutrophils and other cellular elements. So these are interleukin 1, interleukin 6, tumor necrosis factor, PAF, eicosanoids as a result of bacterial endotoxins. And these bacterial endotoxins are lipopolysaccharides. So these lead on to all those symptoms of shock, though there is no external loss of the fluid or blood from the body. So what are the various symptoms and signs? So symptom and signs are generally almost overlapping Just hold on. So we can open. So symptoms, there will be obvious source of infection with predisposing condition, urinary tract infection, low immunity of the patient, diabetes mellitus is there, other cardiac problem is there, malignancy may be there. So all these are predisposing factors that can cause even the minor infection to flare up into a septic shock. When the patient goes into shock, there is hypoperfusion to the brain, patient will be confused or maybe comatose, and it may become restless. Initially, the skin is hot and flushed because of hyperdynamic circulation, and ultimately, when vasodilatation and permeability of the vascular system increases, the fluid loss from the system goes out into the third space. So that will lead on to then cold peripheries. Bounding pulse will be there ultimately. That bounding pulse in the later stages will lead on to only feeble pulse or absent, even diastolic circulation. So vasoconstriction and classic signs develop later on in the later stages of the shock. So what exactly is the treatment of your septic shock? So as we have discussed, the main cause of septic shock is obvious source of infection along with the predisposing conditions. So if we can remove those predisposing conditions, we can control the endotoxemia. That means we can control the shock, and that we can control only when we have intervened in the initial stages, when the patient has some reserves in the body. When the patient comes in the later stage, when the blood pressure is not palpable, diabetes is also there, other cardiac problems are also there, in those cases the chances of mortality are very high. So now dive into the mind map to see what we have for the treatment. The same is resuscitation of the patient. That means we have to maintain the airway, we have to maintain the large bore cannula to infuse the fluid to the patient. So identification of the source of the infection. So when we have identified the source of infection is our urinary tract infection, and the most common cause of urinary tract infection is gram-negative bacteria. So we have to start broad spectrum antibiotics that can cover the gram-positive, negative as well as anaerobes, because until all the results are available, we do not know whether what kind of organism is causing the shock. So we have to cover all the three types of organisms, gram-positive, negative as well as anaerobes. So antibiotics we have to give, that depends upon the site of the sepsis. So that site of sepsis, here is proper history to ascertain the site of the infection. The patient may give a history that he is a burning micturition or GI tract. The source of infection, if there is any wound in the perianal area, that can also lead on to gram-negative infection. Urinary tract infection if it is present. Then secondary to intravenous lines infection, that is a cross infection from the neighboring patient to this patient. If the patient is having the previous antibiotic therapy, that means that patient may be suffering from some resistant organism that may be acquired from the hospital. So that we have to also take into consideration to treat the patient, because such kind of patient may require different group of antibiotics, and in those cases we have to discuss with the microbiologist of the hospital. So what are the various flora that is present in the hospital environment, and what are the antibiotics that are working on those organisms, so that we should not waste our resources, our time and the patient money also. So these are the things that we have to consider while treating the septic shock. Like any other shock, as I have already told, airway has to be maintained, circulation has to be restored with the plasma, expanders and the crystalloids. Urine output is very essential because this urine output does two functions. First, it gives the indication that whatever the fluid we are giving, the patient is responding if the urine output is increasing. If urine output is increasing, that is a good sign that blood pressure is increasing, renal perfusion is increasing, and kidneys now have started producing the urine. That means kidneys are not going into failure. So central venous pressure also to measure the response of the fluid to the shock. When the patient is responding, that means central venous pressure will keep on increasing, and with maintaining the central venous pressure we can also avoid the overloading of the patient circulatory system with the fluid we are giving in. So we should not be hyper perfusing the patient with the fluid. That should be inadequate amount. Then surgery. What is the role of surgery in the septic shock? When we get to know that patient is having obvious source of infection, if it is a abscess, we have to drain out, like perianal abscess, ischiorectal abscess, or there may be some urinary tract abscess, that is your pyonephrosis. So in all those cases, until unless we drain the pus, so antibiotic will not respond too much to treat the infection. So that has to be drained out. So that means source of infection has to be eradicated from the body. So next is the length of hospital stay. Length of hospital stay of the patient depends upon at which stage that patient came to the hospital, number one. Second is what are the various organisms that are causing the septic shock. If those organisms are resistant organisms, that means patient may require longer time because the effect of the antibiotics may be not as strong as in case of sensitive organism. So it depends upon the community infection, respiratory tract, and different antibiotics are required for that. If nosocomial infection, that is a hospital acquired infection, that means we have to give antibiotics depending upon the prevalent bacterial flora in the hospital environment. Then what is the cause of local recurrence of the shock? That means patient is still having some latent bacterial source. So that ward patient is repeatedly having infection from the other patients. ICU patients similarly likely to be having more resistant infection. And if the patient already had visited some other hospital previous to this admission, patient may have acquired infection from that hospital. So that we have to consult the microbiologist of that hospital, and according to that we have to give appropriate antibiotics to the patient. Then what are the surgical procedures that we can perform over these patients? As I have already discussed, drainage of the abscess. If the peritoneal cavity is having some collection because of perforation from your typhoid perforation of the gut, or there may be some other cause that has caused the perforation of the large gut, colon, or the rectum or the sigmoid. So that can also lead on to septicemic shock if these are not drained in a time and the perforation is not repaired within a time frame. So what are the supportive measures? As usual in all shock cases, we have to give inotropic agents and the ventilation when the patient is going into confusion and ultimately into the unconscious state. In that case, we have to intubate the patient and we have to give ventilatory support to the patient. So complications of the septic shock, as I have already discussed, it is a part of systemic inflammatory response syndrome. That means first it will affect the lungs, it will lead on to ARDS. That means, what is the meaning of ARDS? Acute respiratory distress syndrome. And MODS, multiple organ dysfunction syndrome. So ultimately when MODS occur, multiple organs are going into failure and ultimately there will be death of the patient. Very few patients come out of these situations when the patient is in multiple organ failure. So ARDS, acute respiratory distress syndrome. So in this case the patient will have ileus, renal failure and ultimately progress on to multiple organ dysfunction syndrome. So when the failure of one organ is there, mortality is 30%. 3 or 4 organ failure, the mortality is almost 100%. Suppose your kidneys are failed, your liver is failed. Even these two organs occupies the major role in the human body. So even these two can fail, the chances of recovery are very, very low. So now we have already discussed the septic shock. Let me close all the notes. So next topic will be our neurogenic shock. So you must be prepared with all these two shocks, hypovolemic shock as well as septic shock, because these are the two common shocks which we have to face day to day hospital environment, in the emergency, in the ICU. So one must know the basics of these two kinds of shock, though other shocks are also important. Thank you very much.